Ben Pearl, and today I have Dr. David Armstrong. He wears many hats, but he's kind of known, I like to nickname him the Dean of Diabetes. And as David Letterman would say in the podiatry world, this man needs no introduction. Listen, David, you've got a lot to talk about tonight, and we're going to get right to it. But one of the things that I wanted to know right off the bat was you got something that has not been done with podiatry. Tell us about that science commendation that you recently got.
Do you mean just a couple days ago? Is that what you were talking? Yeah,
So I saw a write up in PM News.
yeah. Oh well,
Yes.
there. Oh well, look, that's all great. And the fact is that I love my specialty, podiatry, and I've been pretty much given everything, so I haven't had many excuses but to kind of pay it forward. But yeah, I guess the most recent thing is that uh, you know, um, there's a way to keep track of uh, of kind of impact for the work. And I guess that was just sent to me by leadership in my institution. And I guess that we're leading the world in that area now and have been for some time. It looks like now for the last 15 or 20 years, but now the data have just kind of come in today. So that was pretty great. I think that's pretty great. Also that, at a big institution like USC that, podiatric surgery is actually, leading in terms of what's called H index and impact factor, et cetera, and number of citations and things. So it's pretty great. But it's the great news is, when you're in an institution, when you're in once you sort of get in, it's a meritocracy. And I know, of course, there are all kinds of things that are unfair in academia. That's for darn sure. But at the end of the day, we always say that your degree and your training, it should define you. I always tell my team, but it shouldn't confine you. And we got
What?
things going on in so
Yeah,
many.
and it's great, and of course you also carry uh, an MD designation. What do you think has been the divide, David, with research with podiatry getting recognized? Obviously, in the United States, we haven't been doing enough of it. I am coincidentally just winnowing my way to try to figure out an IRB with Ascension in Indianapolis with Pat Dehere's program,
Awesome.
Dr. Dehere. Yeah, so I mean, but let me tell you something. It takes some doing. But what I want to know from you, because you're in the walnut rooms with these guys from Davos and Munich. What is it that podiatry still needs to do? If you could spell it out, so that we get on a more equal footing, to use a pun.
Yeah. Well, I think it's already happening, really. I think the good news is that look, when I was first getting started, I was pretty used to being first of my species, or and trying to have to explain to every woman and man that I was meeting, how many years after high school, my beautician degree, but took. But now that doesn't happen as much anymore. And I think the good news is that that we're having now young, women and men in other areas of specialty that we are mentoring. I'll give you an example. So there's something in the National Institutes of Health called a K Award, and it's a career development award. It should be a C, but they use K. And they're really coveted. Maybe coveted is with a C and not with a K. But these K awards are really coveted, and I have I'm really lucky that I have four mentees that I'm mentoring along. Two of them are vascular surgeons. Um, One of them is in my institution here. One of them is heading over to Duke now from West Virginia. Another is the first ever podiatric surgeon, Brian Schmidt. That's a great guy for you to interview. He's doing awesome stuff with metabolomics and next gen kind of microbiome. You got to interview him, Brian Schmidt. And he's a Big Blue, University of Michigan, and then Bill Padula, who's actually a pharmacoeconomist. So, but when you have a foot doctor, podiatrists like me, kind of mentoring those folks along. You see now, uh, things are already happening, and folks just now take it for granted. When I go to our meetings, like when I go to our DEF CON meeting, right? I look out in the audience now, and I see her, and she has a big NIH grant. I look at him, and he just published that big thing, in New England Journal, and I look at her in the back, and she just started this big unit in Chicago, and I see. And this kind of thing now is happening more and more. And it used to just be, n equals one. Now it's decidedly more than that. But what we still need to have is we still need to have this stuff get more and more common. Look, we have, we should have each and every resident in the country working hard in teaching hospitals and understanding that they should be doing, if the mood strikes them, they should be exposed to an academic environment, and that may mean doing clinical research and being involved in it. It may just be being adjacent to it. I think most of the medical students that aren't podiatrists that I mentor have no desire to go into academic surgery or academic medicine, but they're really interested clinically, and they respect the craft. I just this morning, 10 a.m. today, I was in a class, first week classes for our medical students at Keck here at USC, and it's a big classroom. I think there's 200 kids in there. Man, they're all kids now. And I was just we had a whole session on research. We had a whole session on managing conflicts of interest.
No, that's great. And I want to interject. Warren Joseph teaches a course in evidence-based medicine. And when I went to school at Temple, although he was great for infectious disease, we did not have those courses. So I'm glad that those are becoming commonplace. Listen, we could go on all night just about that, but you've got some transformative research that you wanted to share. And I really want you to kind of dig deep into what you think will impact not just the guys in academia, but the guys in the trenches, the guys in the salt mines.
Let's talk about stuff that's happening right now. In our unit, we got tons of projects. Everything from spread on and spray on skin to wearable robots to gene therapy to all these really cool things. But let's not talk about those. If you want, we can touch on those later. But actually, I'll tell you about something that I think is more important than all of those, and that is just good quality offloading for us. And we have a really big study now funded by our U.S. National Institutes of Health, by the National Institutes of Diabetes and Digestive and Kidney Diseases, to be specific. It's called the Smart Boot Study. And so check it out. We've all learned that, the gold standard in treating diabetic foot ulcers for offloading is a TCC, a total contact cast. The trouble is most places don't use a total contact cast because they're, hot, heavy, or they're expensive, or, there's some reason, or patients don't like them. But most people use boots. The trouble is when we check how much folks wear the boot, we see from work that we did about 20 years ago, where we actually put activity monitors on the boots and activity monitors on the patient. These are in the early days of what people now call wearables. We found that folks were only wearing their device for about 28% of their total activity a day. And these are people with wide open plantar diabetic foot wounds. And we wonder why, when we put all this fancy stuff on the wound's not healing. Well, there's your answer. So what we did back then, because folks weren't wearing their device, we said, well, let's just take that boot that they're not wearing and literally just wrap it or put a little lock on it, wrap a Coban or some plaster around a removable cast boot. And we called that an instant total contact cast. And we figured anyone could do that. And it turns out that does really well. It was healing people about as well as a total contact cast. But people still hate it because they have to keep it on. So this study is trying to figure out how can we meet folks in the middle a little bit. And it's really practical and pragmatic for us. And so we are now randomizing folks with a boot that most people will want to wear because it looks kind of cool. It was designed by this guy, Mike DiTullo. We should put like a link in the show notes, Ben, so people can see all of this stuff. Mike designed second and third gen of Air Jordans, I think. But he and there's another podiatrist that has a device called I don't know if you know Jason Hanft.
I don't.
Oh my God, you got to interview Jason. Okay, so Jason's elite, world class diabetic foot researcher and just a great clinician. He and his wife Maria Supernat are in Miami. But he started a company. It's called, I think, Defender Boot, and they have a nice looking boot, and it offloads as well as the best other boot, but it looks good too. It's just designed nicely. And we're randomizing folks into a removable device, although we're counseling folks and telling them to wear it as much as possible. B, that same version, but it's irremovable, so we're locking it. Or C, a smart version of it, and we're putting a little wearable on the device, and it's linked up to a smartwatch that we give our patients. And what we're doing, we're trying to do something with the patient and not to them, in that we're saying, hey, Ms. Garcia, your device, that's a great device, and I see you're wearing it here, but you're only wearing it for about 10% of your activity. It must be sitting next to you in your house as like a doorstop most of the time. How can we, what can we do? Oh, Dr. Armstrong, it's heavy and it makes me big. It makes me really, I'm unsteady, or oh my God, I have to drive the kids and I have to take the bus and I can't walk. So we figure out these problems and then we start addressing them, but we're certainly registering them. And this kind of thing is bringing us front and center into what we deal with on the day to day. And people call people non-compliant or whatever we call them, or non-adherent. But man, this stuff is hard, and it's easy to write a prescription for a patient. It's easy to dump someone, say, oh, blah, 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 and just walk out of the room. What's hard is to try to meet folks where they are and try to go to the mat for them. And we all do that in podiatric surgery. And this is kind of where it's at. And we're really excited about what we're going to be seeing with the data. I mean, it's already extraordinary and it's very, very interesting.
Speaking of prescription writing, there's another hot trend. And I actually asked Alan Jacobs this question, and he's not been, look, everybody's heard of Ozempic. He just hasn't had enough clinical in his own clinic to be able to thoughtfully comment on or want to comment. But you're also in an institution, and what do you think about the projections with Ozempic and the analogs with diabetes? And is it being overhyped, or do you think that this really is going to have a role that will have a downshift on the curve significantly, and to what degree would you project?
I don't think
maybe these are a lot of open-ended questions, but
anyway. Well, these are all great questions. By the way, Ben, even if they weren't great questions, I would say those are great questions. But those are great questions. But listen, the thing is, no, I don't think this is being overhyped. I think that this is real, and I think these are having the GLP-1 agonists are having an impact on patients, and is it perfect? No. Are they perfect? No, but they are definitely transforming the lives of people. They're changing people's relationships to food, and people are losing weight. And this, writ large, as soon as we can start getting this to our patients, it is just so exciting.
Is this a conversation you would ever have
with
a patient, or how does that go in your institution, or is it already?
My God, so look, I saw, what did I see? How many people did I talk to them last week or just on Tuesday? I think I probably talked to 18 or 20 people about Ozempic in my clinic.
And
of those, I should say that already half of them were already on it. And let me tell you, the people that I saw, thank God, I'd say maybe half of them were wealthy. Half of them were not at all. Half of them were actually, Medicaid patients who were, paycheck to paycheck. and who I've worked with, they're like these folks are like our family. And but all of those patients were on Ozempic now, or on a GLP analog, or agonist, I should say. And so the fact is that this kind of thing is uh, affect. And by the way, I'm also having to modify my kind of surgery schedules a few times. I've had to cancel some cases already because there's so many people on GLP-1s because anesthesia wants you to stop folks, I don't know if you know, a week in advance now, because of some risk of some yeah problems with gastroparesis, which can happen. So that's yet another thing. So I'm seeing that surgically too on the OR schedule. But I do believe. I mean, could you imagine now if we dramatically reduce diabetes, that downstream over the next 5 to 15 years will have a dramatic impact on lower extremity complications of diabetes, just because we'll have so many fewer ones. I mean, I think that's glorious, frankly. However, what we're also seeing in our patients is we're seeing, people that have diabetes and have, they're living longer with diabetes, and they're living longer with complications. And these folks are getting more and more wounds. They're getting more and more renal disease, and obviously also peripheral artery disease. So we see people with really end stage complications so much more frequently now. Fully 40% of the people in our flagship clinic, 40, are on renal replacement, are on dialysis. And that's amazing. If you would have told me that, 20 years ago, I would have said that's just it, because these folks are so hard to heal. They're so hard to treat. They're just almost a special class of patient. But so we have these different bits of demography that are hitting us all at once. Number one, we have patients getting younger and younger with type 2. And then we have people getting older and older with type 2 because they're living longer. So we have these two humps. And then we also have things like drugs and like the Ozempics of the world that are maybe fundamentally reducing overall prevalence of the disease in the background. So this is all having dramatic impact. And it's not just having impacts on what we're talking about. It's having impact on vascular disease potentially. It's potently anti-inflammatory. It's also having impacts on people's other kind of cravings, like smoking or even substance abuse. So and drinking. So this kind of thing is it is super exciting. It's a fun time to be doing all this.
Well, I want to get back to a couple other things that are swirling around, and there's been some guidance for skin substitutes, and I know some of the ones that you and I both use.
Yeah.
One being the codfish from Iceland, and we were both at the
Yeah.
Iceland embassy recently, and you
Fun
you
seeing
got
you, man. It really was. Yeah.
it was a great event.
Yeah.
You actually said something cryptic, which maybe you can explain. I was going to ask you before, but we'll wing it now. You told the ambassador, congratulations and condolences. What were the condolences for?
Oh, I was just making a joke because I can only imagine, man, how hard that job is.
Oh, okay. That's what
And,
I thought it was. That's what I
and
thought.
it's just, just trying to get out in front of things
Right,
so that was
right.
the condolences bit. I was saying the same thing to her before I walked up to give that
Okay,
keynote. So I just said it again because, yeah, but yeah, she's terrific, actually. Really impressive. Uh,
okay. I just wanted to make sure
oh,
Iceland
that,
wasn't
that's right.
totally melting away unbeknownst to me or something.
God, I hope.
Well, so what's the word that you hear? Do you think, and maybe this isn't in your wheelhouse, but do you think that that the data they are going to present is going to be strong enough with the comments to get everything on board?
Yeah. Do you mean are you talking about for specific?
Some of the requirements for insurance requirements for some of the skin substitutes.
Yeah, yeah. So as you know, CMS have essentially sort of. I think there are like 200. I don't know how many. There's a lot. There are a lot of approved so-called skin substitutes. There are camps, cellular, and matrix products, or whatever it's called. But they're but uh, many of these are um, just small companies that will manufacture something but may not have a lot of data to support it, and are just relying on other companies that have done these studies. But I believe what CMS has done is that they have picked, I think, you may know this better than I do, but I think they picked like 15 or of these products that have data, and said, okay, we're going to approve you, but not any of the other ones. And I think that's raised a bit of a hue and cry amongst other, not only docs and even patients, but companies as well. And so you have kind of an
Some of
effort.
which have done robust research, like
Oh,
Kerosene,
yeah,
as
that's
an
right.
example.
That is
Yeah.
true. Yeah, some of whom have done zero projects, and others have had really robust development programs. You're right. So and so what do I think is going to happen? I don't, I think there's the great line from Oscar Wilde, who said, prediction is always difficult, especially when it concerns the future. But what I will tell you is that if I were to, I think that CMS, this is not by any stretch some evil cabal or evil cabal that are trying to sock it to humanity. I mean, I think most of the people that I've talked to I mean, a lot of them are practicing docs. A lot of them are docs. And I mean, and I think they really care about what they're doing, but they have the hardest job in the world, because it is, for them, in many ways, it's a zero-sum game. They've got to figure out how to deal with finite resources, and giving them as much information as possible is really important. And one of the things that happened was that I think they only approved a certain number of applications. It was only like, I think, 4. Is that what it was? It was something small, or not a lot of them.
I think it was more than that, but
Was it more?
yeah.
Okay, well, better, maybe I. But bottom line is that what it was, it may not have been enough, and they took some of those data from a study that we did, but they didn't. It wasn't really looking at the data correctly. They just looked at the average, and they didn't look at the fact that there's a lot of patients on the other end of average, that when you look at how skewed things were. So they just said, okay, only this much and not any more, which I think hamstrings surgeons that are physician surgeons that are really caring about this problem. So that.
Well, David, I've got a few case studies that I want to take a look at, but before I do, and it
Yeah.
will relate to a couple of the case studies, what is your feelings on, and this was brought up to me by a colleague, and I've been talking to Warren Joseph about this.
Yeah.
We've got some archaic research on osteomyelitis with 6 to 8 weeks of IV antibiotics, or
Right. Right.
what has been your thought process? And obviously, debridement is a part of certain things when it gets to a certain stage, but
Yeah.
maybe kind of give me what you're seeing,
Yeah.
and also any research that I may not be aware of that has a different spin on the new norm for how long antibiotics with diabetic foot,
Well,
as we get into bone especially.
yeah. So if we're talking about specifically about osteo, I think people overtreat it. So I think in many cases, it's look, osteomyelitis is important, but it is not that big a deal. It doesn't wake you up at night. Very few osteos become raging, rip-roaring, necrotizing soft tissue infections. Osteo is, you usually have time to react. You don't need to go bounding into the OR at 2:30 in the morning. It's just that's what, necrotizing infections do, will wake you up, not this. So we often will make a really big deal about this. We say we have to cut something off. And sometimes you do if there's just no bone left, if it's all totally destroyed, but very seldom do you have to cut a whole leg off because of osteomyelitis, right? I mean, it's just not true. But we can do targeted surgery where we resect the bone, and then balance the patient through either through soft tissue balancing and also from bone balancing to try to spread that force out over a larger unit area. But as far as treating osteo, people can treat some osteo now to suppression. And one of my really close friends, you ought to have him on this show, is Jose Luis Lazaro Martinez from Madrid, from the Complutense, and he's done a tremendous amount of work with one of my other friends who's from Gran Canaria, and Javier Aragon. But they've shown pretty conclusively that you can treat some patients to suppression, and you can just do isolated resections and get very good results.
How are you generally mapping out your procedures? You've done x-rays. Let's say you have the mid shaft of a metatarsal that is necrotic. It's a submet 2 or 3 ulcer. What are you doing generally with your cases? What tests are you ordering after your initial x-rays and your clinical exam? You probe to bone on the metatarsal heads. What next?
Yeah. Well, I think
in your algorithm anyway.
Yeah. Well, I'll just say that I think that very often I think one of my favorite acronyms is victim of modern imaging technology, or VOMIT. And I say, we got a VOMIT consult or something or other. And how many of us have gotten these? My friends in vascular surgery get them all the time. They get to say they got an MRI or something, they got the carotid showing 90% stenosis in an asymptomatic patient. How are you going to treat it? For us, very often it's osteo, maybe on an MR, and there might be some osteo. Clinical correlation is important. And so then you go down with this VOMIT consult, you go down this diagnostic and, God forbid, a therapeutic rabbit hole, and you often are over-treating patients. So I am a notorious underutilizer of tests. I mean, the time I use a test, like an imaging test, is when I am going to say, if this, then this. And so I may get an MR to help if I'm concerned about maybe retained soft tissue infection or an abscess, or if I want to see the extent of osteo, kind of maybe, or if I want to have a reconstruction plan. But even then, sometimes I've been moving to some CTs for that for Charcot. But the fact of the matter is that I think what we can do is get serial radiographs for a patient that just has a little bone. Something that probes down to bone, and has, I think, taking that patient in and doing and then doing a resection back to a clean margin. And when we get a clean margin, we get 3 samples in the OR. We get 2 histo and 1 culture. The 2 histos are a clean margin and a dirty margin, and the microbiology, the micro is just a dirty margin. That's what we call everything, and this is what we tell, and then that's it.
Well, that's a nice way that might potentially save you from another imaging test down the road after you close up your met head resection or what have you. And I'll review a case in a second that was a little more murky. But I like that idea. And on this particular case, I got I tried to do that, and with this particular case, and part of the head of the metatarsal head had retained to the soft tissue underneath. So I kind of grabbed that out, and so in all that kind of hustle and bustle, I didn't have 2 particular specimens, but I think that's a great idea, and one that should be followed. That's a really that's a good, unless it's something obvious like you're doing a toe resection and
sure.
As far as the serial x-rays, it's interesting you mentioned that, because in some cases our ID colleagues will want to hesitate with that, treating the osteo to quiescent to
Yeah.
get it to hopefully be quiescent. But then sometimes you literally see, and in this particular case, there was a delay, and we literally saw the base of the proximal phalanx and the head start to dissolve on this Met case that I'll show in a moment.
Yeah.
Uh,
By the way, on that note, importantly, if a patient, I think the vast majority of data show now, if a patient has a functioning gut, then um, generally speaking, oral is as good as parenteral. And as long as you have a sensitivity to what you're, treating, it's okay to treat someone to suppression with an oral. It's okay not to have someone on 8 weeks of a PICC line, because PICC lines PICC lines are not benign. I mean, you often will get a complication with a PICC line, and that complication is often an infection caused by the thing that's supposed to be treating an infection. So it's life out of balance, man. And you don't need that.
not to mention the expense of the PICC line.
Oh yeah, exactly. It's just, and patients hate it. I mean, but so if
That's where, and I know Warren Joseph's real excited about omadacycline. That's where some of the new wave of antibiotics that are picking up some of the resistance, and still, you end up sometimes with gram negatives that you're still wondering, well, what is the capability? How well will that omadacycline cover the E. coli, the Enterococcus faecalis? But it is something that is being used for those types of bugs. Whereas before, when we just had something like doxycycline, we were more towards the positive end of the spectrum.
Yeah, there you go.
All right, well, let's take a commercial break for 1 nanosecond. I'm going to go get this case so you can take a look at it. I'm going to pause this for a sec. Hold on, David. Okay. So this was the post-Met head resection at 2 weeks. And he had been on omadacycline and then changed to Dalvance, and he was also on Zosyn. So this is where we're at. What would your next move be here with this situation? And this was, as I had mentioned before, where prior to this, the Met head was dissolving, and it was taken to the surgical neck. So you get your X-ray, and you see that there's a little bit of erosive change now on at the neck.
And how about the base of the toe, at the base of the metatarsal? I mean, at the base of the proximal phalanx.
Yes, that is also looking more osteopenic.
Okay, so I mean, I would probably, so what I'm seeing based on what you're showing me now. By the way, what is that kind of in the wound? Is that some sort of like dressing? Or is that just slough or?
So we had packed it with an alginate dressing.
Oh, I got you.
Yeah. Yeah.
Okay. So what it looks like right now, it looks like there's some retained. I mean, when I look at that with the erythema there and the edema, it looks like there might be some probably retained infection, probably retained osteo. I probably have the patient back and either I'd probably have them in, and I'd probably try to get back to a clean margin on the toe distally and proximally on the metatarsal, and I would take it back again to some good healthy bleeding bone, and I would get a clean margin there, and also a dirty margin to get another a culture. And I'm assuming you had mentioned with all of those drugs like Dalbavancin, the patient must have MRSA. Is that why the patient grew that?
Yeah, that was the initial bug, and then the first operative culture of the Met head resection just showed Candida, which we were just determining was overgrowth, presumably.
Yeah, all righty. So I mean, that's what I probably would just take that patient back to the operating room. The other possibility would be, just to if you saw, because that toe, of course, has kind of a sausage toe appearance, which is often pathognomonic for osteo anyway. One may consider if you can't get back to a nice clean margin there distally, to just do a partial ray resection, and really split things open and get a really nice wide excision, open things up, wash it out, wait for the erythema to reduce, and then start easing things closed, with just slowly.
Well, I'll tell you what I did do, because there was a lot of hesitancy in this particular patient. He was concerned about foot function.
Uh-huh.
And I did mention to him, I was also concerned that we would hopefully be able to, any subsequent surgery, be able to preserve the tarsometatarsal joint so
Uh-huh.
that we didn't start a cascade of a Charcot foot.
Sure.
So now I think there's nothing wrong with your approach of the margins and just relying on your clinical acumen, but I opted to get an MR. It did add a little bit of spice to the case, because this is the MR. And let me see if I can get it without reflecting. And
Yeah.
I don't, can you see the little light green
Yeah. I do.
notation there? Do you see that?
I do.
So what was thought, and this is the T1, is that right where that line was, the
Yeah.
concern was that the edema that
Yeah.
was, and I'm trying to get this so it's not
Yeah.
shadowed,
That's all
but
right.
the edema that was on the base of that bone, that was concerning to the radiologist reading it. So he said that in these cases, he doesn't follow the T2 as much because we had the gallium enhancement, but he
Yeah.
was very concerned about that. So based on that, we were getting very, very close to
Yeah. You are.
the tarsus there.
Yeah.
So at any rate, subsequently we did go in and resected, not quite to as far as that arrow would indicate, because
Right.
as you sort of mentioned, the bone clinically looked pretty robust once we got to a certain point. So this is what we ended up with. I don't know if you can see that clearly. And that
Yeah. That
bone
looks great.
proximate,
Yeah.
yeah, it looks pretty solid.
You
Now,
can by the way, you can also obviously, if you want to get a high level of antimicrobial in there, you can antimicrobial. You can pack it with uh, uh, you can obviously pack this with an either an absorbable,
these,
either calcium sulfate or phosphate. So there you are as well. All of that's possible.
yeah, and then just to bring it totally up to where this was, just after, it's improved, but still not totally out of the woods. And I think the swelling has certainly come down, though. And I'll show you a clinical photo
Sure.
momentarily. The next case is going to be regarding your toe and flow, and that also is still in the midst. And one of the things I wanted to ask you while I'm loading this up is, do you find more impact typically on most of your diabetics on the arterial side, the venous, or is it about 50-50 in terms of how much work is being done on the venous versus the arterial? Because I'm starting to see myself a little more venous than I thought. Uh, and let's just hold that for a nanosecond. And here's where we are. So still a little concerning, though, right?
Yeah, it's
This
still a little erythematous,
Yeah,
but
but the swelling has gone down. He had a big soft tissue pocket,
yeah,
and we left a little drain, if you will, distally there.
got it. Did you do
And
anything? How about planarly? Did you?
yeah, I
Uh,
clean it up, and that seems to be healing better than the dorsum.
Great.
Uh, Interestingly enough. So and that leads to another thing that I guess goes along with experience. In your estimation, how long do some of those erythematous changes linger in the soft tissue itself, and yet you still might be kind of over the curve of infection, or what's your thought process with that, chasing the look of it post-surgical?
Yeah. Well, look, I think that we all have we all kind of respond to pattern recognition, don't we? And from our from our experiences, and I have a lot of experiences with a lot of patients that will have kind of this slow kind of decrescendo of swelling over a long period of time. But as long as we're seeing things moving forward and we're not just stuck in this kind of this sort of purgatorio of of edema. I think, and a draining wound on the dorsal aspect of the foot. Although a draining wound on the dorsal aspect of the foot is so much better than a draining wound on the bottom of the foot.
Yeah.
God, but that's a lot easier to manage. And so,
Well, let me show you one more case real quick, and this is kind of hearkening to your toe and flow model.
uh-huh.
Um, this came in and it really just looked like a carbuncle. So
Yeah,
initially, so I drained the carbuncle,
yeah,
and then this ensued, and it grew out a mixed bug, and
uh-huh,
I had put this patient empirically on omadacycline,
uh-huh,
and well, then what happened is the ulcer sort of opened up and kind of herniated, like almost like the fat was extruding. I don't know if you can appreciate that in the picture. What would your next move be with something like that?
Well, you said the fat was kind of herniated. I didn't see that.
Yeah, on the wound, like let me
It
just.
wasn't granulation tissue that was.
It's some granulation, but it looked as if there was like also a little bit of fat, the underlying fat underneath the dermis.
Uh-huh. Yeah.
Anyway,
Uh, well, I mean, so let me ask you.
it's only
Uh,
about 2 by 2 centimeters, so it's not a large wound,
yeah,
but it.
I think if you're concerned about the wound, I mean, you can obviously get a biopsy of the thing if you're concerned about the way it's looking. That's something that we probably don't do enough collectively.
And the
Um,
pulses were not good. I should have told you that. The pulse
okay.
non palpable pulses, and there was this picture I showed you. He had more swelling prior to the picture that I just showed you. So what would your next set of steps be in your hands? What do you generally do with that?
Yeah, obviously, this is the kind of thing where I'd get non-invasive vascular studies, and I'd also at the same time call my flow migo, who's right across the hall from me, right? And so we have these kind of forced curbsides, and it's just great because we can have him or her, in the room, lickety split, and then uh, we just probably assess those non-invasives and see what they were, and if patient could be intervened upon to try to improve what might be an ischemia dominant condition.
Yeah, so that's exactly what I did, and that ended up. And I'm just trying to see if I can open this up, David, so we can see it a little bit better. And what ended up happening is that it was on the venous side. I had sent for ABIs because I couldn't feel the pulses, and they said, yeah, we're probably going to examine the venous, and that's what they did. Um, and so I'll try to put this as close as I can. This is the diagram he sent me
Yeah.
back. So all three of those vessels, the greater saphenous and the lesser saphenous and accessory saphenous, were not optimum.
Yeah.
And do you see a lot of that where you're in your clinic where you're having to have venous ablations to get the deeper vessels to do their job to get
Yeah,
the.
that's pretty awesome. It's not common. We definitely see it, but it's not common on the foot. But obviously we are used to seeing that, in the so-called gator area of the leg, or even laterally on the leg. And we see obviously so many venous leg ulcers, but it's not common, but again, it's not unheard of. I have a patient right now, I just saw on Tuesday, that definitely has both diabetic foot, it's mixed etiology, DFU and VLU. And so those are definitely ways forward. And uh, uh, we definitely will have that patient assessed for benefit for venous ablation. And because the data are actually pretty strong for venous leg ulcers, for healing and also for recurrence. That if a patient has a something that is um, incompetent and that can be and she or he is a good candidate, that endovenous ablation can be really valuable. It can be very, very, and I think a lot of times, we end up nursing these wounds um, when we should be doctoring them as well as nursing them, right? And so this is one of those kind of situations.
Anything you do post procedure that's easier for compliance, as we all have patients that just won't wear the compression garments. Anything new happening in that space that you're
Yeah,
aware of?
that's a great question. Well, obviously, we try to get patients to wear compression garments as much as possible. One of the things that some people will, if we can get it for the patient, there are some really nice home compression devices now that are used for lymphedema. And if you can get kind of a quasi-diagnosis of concomitant lymphedema, then that could be, useful. We also will have people do, some of our uh, team in OT and in PT will do MLD, manual lymphatic uh, drainage on some of these patients, and our patients kind of find that really satisfying as well. And so that's yet another possibility too.
Well, we're in the home stretch here, getting to the top of the hour, David, and I would be remiss because you're such a geeked out with AI on where you think AI with either wound mapping or prognosis. Look, you can put symptoms in, and our patients do this sometimes, and you'll get a whole workup. So,
Yeah,
uh, where have you been using it in the clinic, and what are you excited about, either visually or otherwise? With
sure. Yeah. Well, we've already published few years ago already on using deep learning algorithms for sort of computer vision. And so I'm happy to give you that manuscript and some of that work that's published in the kind of the mathematics literature.
well, what
And
came out of it practically for that
well,
would change how we operate?
yeah, yeah.
What are you seeing that's more
Yeah,
defined as
what
an
we were
example?
seeing in that study was that we could identify wound margins better than we thought. Because, strangely, and I know everyone knows this that does this work, it's if you've used any of these, wound planimetry devices, and God knows I've forgotten how many we've used over the years. It's just I can't count. We've been doing this with enthusiasm for like 25 years since we were using the first computer planimetry devices. What we have found, unfortunately, is often finding the margin, finding the wound edge is hard. Some of the new algorithms that we've actually posted these algorithms um, that that actually is doing a better and better job of identifying the periphery. Another thing is my friend Moy Hoon Yap. She's in Manchester, and she helped to. We participated in what was called the Diabetic Foot Grand Challenge, which was to which was just have a simple or not so simple mobile phone, be able to identify a diabetic foot ulcer autonomously in under 10 seconds from a photo. And all of those data and the library, the AI library, has already been published. That's been done. So that is really exciting because that's basically free to be able to do those kinds of things. We're incorporating those things into what we call our foot selfie program, which has really been kind of AI dominant. And at the same time, I'm beta testing a cool software that's basically like it's just like a scribe. If you've ever had a scribe with you in your office, it literally is one. It doesn't
Yeah, there
like,
was one at the APMA National
yeah,
that
there you are. It
there was
doesn't,
a
yeah,
company. They
it
gave out
doesn't.
some chocolate. I won't mention any
Well, there you go. But
mention any
it
names.
doesn't, it doesn't record the conversation, but it transcribes it, and then it summarizes it. It even gives you some suggestions for ICD-10 codes. It's pretty awesome for those things that, but and I've been using that now a bit. And I must tell you, I'm happier and happier as I use that in the room with me. as well. So
And
I
it
think
probably
I,
has a kind of a learning curve
sure,
within the AI system. It learns what
yeah,
you're, yeah,
it
that's awesome.
doesn't. It's that is getting better and better. And I could, now, I've got little kind of almost macros built in because it's learning and it's getting a little bit better. So I think those kinds of things are now with us. So for sure, and I'm actually for one I'm thrilled for the most part. I think it's an exciting time to be doing this kind of stuff for sure.
Well, listen, David, thank you so much for doing this. This is actually you had thought three. I think this is our fourth because we did that team thing with GW. So this is
That's
actually our
right.
fourth
That's right.
round with it.
With GW, I remember that. Now one of my daughters, she just graduated from Georgetown, but now she's going to GW law school. So there we go. I should have mixed that into the mix. That's absolutely terrific. Well, listen, awesome. Onward and upward, man. Ben Pearl, you're great.
I appreciate it.
Thank you,
All
Dr.
right.
Pearl.